So for this part of the dopamine module, we're just going to review questions that pertain to dopamine, logistical factors, and overall how can we optimize giving dopamine and make it as easy and as effective and safe as possible. So for the first question, so can dopamine be administered through an intraosseous? So any medication that can be administered through the intravenous route can be administered also through the intraosseous route. However, under current medical directives, we can only give dopamine by the intravenous route. So imagine you do a cardiac arrest, you can only obtain an intraosseous and they get a ROSC and you need to give dopamine. It's like technically you'd have to patch to use it. Part of the rationale behind that is that you may need a pressure infuser with some intraosseous, and if you have a rate controller or Buretrol to administer the dopamine, it won't actually work that way. So that's part of the problem. But yes, technically you would have to patch to use it, and any drug that can be administered by the IV route can also be administered by the intraosseous route. How does dopamine compare to pacing in cardiogenic shock? So a couple really small studies have actually compared these two. One was in the pre-hospital setting in Toronto, actually, like years ago. But overall, they're equivalent for effectiveness, and there was no significant difference in adverse events. So pacing and dopamine for those patients experiencing bradycardia and hemodynamic instability, both were equally effective and did not have any serious adverse events. So that's interesting to know. Why does dopamine cause necrosis if it goes interstitial? So this is primarily because of dopamine's alpha effect, so it can cause vasoconstriction of tissue, but overall that reduces blood flow and can lead to ischemia and subsequent necrosis, and patients could lose limbs potentially, and it could be rectified just by surgery. So it's a potential very serious side effect, and that's why it's so important to have a designated line and keep monitoring that site and make sure it's patent before we actually administer it. So if a patient is bradycardic and experiencing cardiogenic shock, do you have to patch before administering any therapies? So under current medical directives, there is a clinical consideration. Consider patching to the base hospital physician if the patient's bradycardic. So obviously you can administer 10 mL per kilogram per minute of normal saline to try to see if they're fluid responsive and get their blood pressure and mean arterial pressure up to perfuse their vital organs. But you can see how this kind of situation kind of intertwines different medical directives. So the symptomatic bradycardia one, and as well as the cardiogenic shock. In our catchment area, it's recommended to start treating the rate-related problem. So we can get them fluid, we can give them atropine and pacing if indicated, not contraindicated, to treat the rate-related problem. And obviously, the more we do this in a quick and effective manner, the safer and hopefully benefits the patient, because any delay in those treatments could lead to adverse and negative consequences. But if the patient does not respond to atropine or pacing, you can consider patching at that point for dopamine and just overall develop a plan for this patient and exactly pick the dose, what are they experiencing, what's their comorbidities, and just try to maintain the best and safest dose for this patient. So what are the best options to administer dopamine? So again, we can administer it through a Buretrol or a rate controller because those are both precise, and it obviously is a lot better than just trying to eyeball the drips per minute in the drip chamber. So if we look, this attaches to a 10 drop set or a 15 drop set. So it can't be attached to a 60 drop set because this equates to a 60 drop set, so it won't work appropriately. And the way we do it is whatever dose you have, so let's say you have an 80 kilogram patient and your first dose is 5 micrograms per kilogram per minute, that will equate to 30 drops per minute. So then you just turn the dial to 30 drops or 30 mils per hour. That just corresponds to the correct dose. And obviously you titrate up. Is this as accurate as a pump that they use in the hospital? No, but it's a lot better and a lot safer than just trying to guesstimate what the actual dose is and how much your infusion, because we always want to know how many mils we administered and what the correct dose was and see how the patient's responding to the amount of fluid and dosages rendered. You can also use a Buretrol, which again may take some time to set up, but again, it's pretty precise and it's a 60 drop set. And again, we can't attach pressure infusers when using the rate controller or the Buretrol, or it won't be administered appropriately. However, for the rate controller, you have to have it at least 3 feet above the patient because it won't flow as appropriately. So you can see how this could be a logistical factor and barrier, because what if you're extricating? What if you're in the upstairs bathroom, difficult extrication with the stairs? It's like, can somebody just stand there holding the bag? Probably not. So that's the difficulty of the pre-hospital setting. Logistics matter, right? So it's maybe like I have to give dopamine. Well, I get them downstairs because no one would be able to hold that up high enough, and just document that. But we can appreciate that.